Today I will be covering about periodontal pocket. So what is periodontal pocket? Periodontal pocket, what is gingival sulcus? Gingival sulcus is a V-shaped device or space which is present between tooth and gingival epithelium. So when the gingival sulcus deepens, that is what we call it as a periodontal pocket. So how do you define periodontal pocket? Pathological deepening of gingival sulcus bounded by the tooth surface on one side and soft tissue wall of mouth on other side. Pathological deepening of gingival sulcus is called as periodontal pocket. So we classify the periodontal pocket depending on the tissues involved. So when there is a gingival or a gingival enlargement without apical migration of your junctional epithelium, those type of pockets we call it as a gingival pocket or pseudopocket. Then periodontal pocket, there are two pockets. Again, periodontal pockets are subdivided into suprabony pockets and infrabony pockets. So, what is suprabony actually? Suprabony means the base of the pocket is above the bone. Infrabony means the base of the pocket is in between the root surface and the bone. So basically, the suprabony pockets are the pockets to bottom of the bone. But in infrabony pocket, the pocket is in between the surface and the bone. Again, depending on the number of surfaces involved, we classify pockets as a simple, compound, and complex. So simple pockets are only one surface of the teeth is involved. Those pockets only on one surface of teeth. That is called a simple pocket. If two or more two surfaces are involved, then we call it as a compound. Spiral means the entrance of pocket is on one side, twist around the to involve the other surface. So most commonly in Caucasian area, this is such type of pockets. Simple, only one surface is involved. Compound, two surfaces. Spiral, a complex pocket. So pocket starts from one surface to twist around the root and involve the other side of your tooth. So these pockets are most commonly in Caucasian area. So what is the difference between infrabony and suprabony pocket? So as I already told, suprabony pocket, base of the pocket is coronal to the alveolar bone. But in infrabony, the base of the pocket is apical to the crest of your alveolar bone. So when you see a bone destruction in suprabony pocket, the bone destruction will be horizontal. But in infrabony, it is vertical bone loss. So when you see transeptal fibers interproximally, they are arranged horizontally in suprabony pockets, but in infrabony they are oblique. So on the facial and lingual surfaces, the periodontal fibers beneath the pocket are normally horizontal oblique course in suprabony pocket. But filial fibers follow the angular pattern of bone loss in infrabony pockets. What are the clinical features of your periodontal pocket? So when you clinically examine, there will be a bluish red marginal gingiva with a gold edge. Color of gingiva will be bluish red, and you will see the reddish blue vertical line which is extending from the marginal gingiva to base of your sulcus. Then the gingiva will be shiny, discolored, puffy gingiva. When you grow, the gingiva will bleed. There is an exudation. When there is a more amount of bone loss, we will see the mobility, extrusion, and pathological tooth migration. How actually pockets are formed? So, in healthy gingiva, the gingival sulcus is the V-shaped crevasse which is present between tooth surface and gingival epithelium. So when starts forming on a tooth surface and there will be a microbial deposits, the body will respond to that with the defense mechanism. So your different cells start coming to the, like neutrophils, they are start coming to a gingival surface from the connective tissue. So when the population of neutrophils exceeds the uh, so when the population of neutrophil exceeds more than 60%, then there will be a the cohesiveness of a junctional epithelium is lost, so junctional epithelium starts shifting to apical cells. That's how the pocket form. Another thing, because of host microbial interaction, there are release of collagenase enzymes. We call them as a matrix metalloproteinase enzymes. So when these enzymes are released, the periodontal connective tissue fibers will get destroyed, and there will be apical shift of your junctional epithelium and again pocket formation. This is one thing. And active fibroblasts are phagocytic collagen, and there is a loss, destruction of collagen fibers below your junctional epithelium. The junctional epithelium starts moving apically and pocket. So this is how the pocket forms. Once again, I will repeat. When the population of polymorphic neutrophils reaches above 60% in a gingival surface, the junctional epithelium starts losing its cohesiveness. So because it starts losing its cohesiveness, the junctional epithelium shifts apically. So when junctional epithelium shifts apically, the sulcus that will be moved. This pathological deepening of gingival sulcus is called as periodontal pocket. So another school of thought is when there is a host microbial interaction, there release a collagenase enzyme, which are called as matrix metalloproteinase. These enzymes will destroy the collagen fibers below the junctional epithelium. So when there is a loss of collagen fibers below the junctional epithelium, the junctional epithelium don't have a resistance, so it starts moving apically. So when it starts moving apically, your sulfur step will be more than the normal, so we call it as a periodontal. Okay. Another thing, the fibroblasts which are present in a connective tissue also, they phagocyte the collagen below the junctional epithelium. Junctional epithelium starts moving apically. This pathological deepening of gingival sulcus is called as periodontal pocket. Uh, Coming to histology, in histology, there are changes on soft tissue wall, and there will be a bacterial invasion. When you see a microtopography of gingival wall, we find a different types of zones over there. On periodontal pocket, it is always in a continuous healing level of what are the contents of pocket and what will be changes on root surface wall. We will discuss it one by one. So when you see a histological section of your pocket, the uh, junction, the circular epithelium starts forming a retipex which are extending to the connective tissue, elongated retipex which are extending to connective tissue. Around these retipex there will be a infiltrate, I mean, the inflammatory cell infiltration around these retipex. When there is an inflammatory cell infiltration, there will be a disformation of epithelial cells that creates an ulceration on gingival uh, circular epithelium. So these are the changes which occurs on a soft tissue wall of your pocket. Once again, I will repeat. So what are the changes in a soft tissue wall? So the circular epithelium starts forming a long elaborate epithelium towards the connective tissue, uh, and there is a diffused infiltration of your inflammatory cells around these reticulums. Because of this infiltration, there is a disformation of your circular epithelium. So this discontinuation of circular epithelium forms a ulceration in a pocket epithelium. These are the two changes which occurs on the soft tissue wall of your pocket. Coming to bacterial invasion, so filaments, rods, foci, these are the microorganisms, and both gram-positive and gram-negative microorganisms. They are present in this epithelium, and few connective tissue have a capacity to invade into it. connective tissue of your gingiva, like T. gingivalis, total intermediate aggregatory bacteria. These are the microorganisms which have a capacity to invade the gingival connective tissue. So coming to microtopography of gingival wall of the pocket. So there are different types of zones we will see on a gingival wall of pocket. So you have an area of relative distance, means there will be some depression where microorganisms starts accumulating. So once they start the area of relative distance, these are the depressions created. After that, the area of bacterial accumulation. So in these results, the bacteria start coming and accumulating the zone. So once the bacteria starting accumulating on epithelial surfaces, so your body will respond to that. So leukocyte will come out from your uh, blood into a site of your microorganism. So that area is called as area of emergence of leukocyte. Then after that, microorganisms are there and leukocytes are there. That's it. Uh, so my area of presence, area of bacterial accumulation and emergence of your leukocyte. After that, both interaction takes place between your leukocyte and bacteria. So that zone is called as area of leukocyte bacteria interaction. So after that, because of the host microbial interaction, there will be intense epithelial desquamation in that area. So because of this desquamation, circular epithelium start getting ulcerated. So once it ulcerated, so you'll see the area of hemorrhages near the ulceration because blood vessels of your connective tissue near to the surface epithelium. These are the different zones which we usually find on the gingival wall of pocket. These are the area of presence means areas of depression where your bacteria start to accumulate. Once bacteria start getting accumulated, your different cells like leukocytes emerge from the blood vessels into the site of bacteria. So once they come there, they will interact with the bacteria. That zone is called as a leukocyte bacterial interaction zone. So once they start interacting, because of those microbial interaction, there is a release of pro-inflammatory cytokines, collagenase enzymes. Because of these inflammatory changes, there will be a discoloration of epithelium. Because of discoloration, we see the ulcerations on a circular epithelium. So as ulceration takes place, the blood vessels in a connective tissue nearer to your surface epithelium, those areas are called as the hemorrhage. That area is called as area of hemorrhage or zone of hemorrhage. So when we say histologically, it will be like this. Area of presence, area of presence, area of bacterial accumulation, area of host, leukocyte emergence, area of bacteria and leukocyte interaction, like this formation of epithelium, ulceration, and hemorrhages. So why we call periodontal pocket as a healing region? Because periodontal pockets are the chronic inflammatory lesions, they undergo a constant repair. So complete healing does not occur. There will be a persistent bacterial attack and continuous stimulation of inflammatory response. Again healing and again inflammatory response. So that's why we call it as a periodontal pocket as a healing lesions. So what are the contents of your periodontal pocket means? Periodontal pocket contains basically microorganisms and their products like enzymes, endotoxins, and metabolic products of microorganisms. Food debris, salivary mucin, nasal clavicular fluid, disconnected epithelial cells. So different cells like neutrophils and leukocytes and plasma cells. Then plaque covered with your calipers usually present on your tooth surface. And there may be a purulent exudate or discharge from the periodontal pocket. These are the content of your periodontal pocket. When you examine histologically, the content of periodontal pocket usually contains the microorganisms, their metabolic products, endotoxins, then food remnants, salivary content, real glycosyl content, disconnected epithelial cells, different cells like neutrophils, leukocytes, and your plasma cells. And you will see the calculus which is covered with the plant. Then there might be a purulent activation from the pocket. What are the changes which occurs on a root surface? You know what are the changes occurs on soft tissue wall of pocket? What are the areas on the gingival wall of your pocket? Now we'll see what are the changes which occurs on the root surface of your tooth. So whenever there is a pocket formation, you will see the area of increased mineralization. First, uh, because of attachment loss, that root surface is exposed to oral environment because your saliva and GSF has a mineral content. That mineral content start depositing on a root surface. Those area will be presented as an area of increased mineralization. And when root surface are exposed to the oral environment, there may be accumulation of your root part, there may be a caries formation. So that caries formation around that caries, you will see the area of demineralization. Then coming to areas of cellular resorption of some internal membrane, we will also see the areas of cellular resorption on a root surface. Area of hypermineralization, area of demineralization, then area of cellular resorption on the cement. What are the surface morphology of a tooth wall? So when you see the pocket, we see the different types of joint. So you see the calculus, below your calculus there will be a plaque which is called as attached plaque. So it is attached to tooth. So after attached plaque there will be an unattached plaque. It is not attached to the plaque. So basically attached plaque is responsible for your carious lesions and unattached plaque is responsible for your periodontal diseases. So below unattached plaque there will be a junctional epithelium. Below junctional epithelium, you have a connective tissue fibers. In pocket, because of destruction of these connective tissue fibers, so junctional epithelium start moving down. Below that, we have a healthy intact fibers. So when you see a surface morphology, these are the areas which you usually come across. Calculus, below calculus, I have an attached plaque. Attached plaque is responsible for caries formation. Unattached plaque, which is responsible for your periodontal diseases to progress. Below that, you have a junctional epithelium. Below junctional epithelium, there will be a connective tissue fibers. So these connective tissue fibers prevents the apical migration of your junctional epithelium. So once they get destroyed because of inflammatory occurring in the gingival surface, then the junctional epithelium start moving apically. So that is what we call it as a pocket. So coming to clinical features, why there will be a color change, consistency change, surface structure change. So there are some physiological reasons for that. We'll see one by one. Why there is a change in color, bluish red discoloration? Because whenever there is a chronic inflammation, there is a stagnation of blood. Stagnation means the blood flowing will be decreased. Because of decreased blood flow, the oxygen content in that area will be very low. That gives a bluish discoloration to that particular tissue. So flaccidity, gingiva is formed naturally because of gingival fibers which are attached to tooth. But in periodontal diseases, we'll see the flaccidity because of destruction of gingival and connective tissue fibers. So pitting on pressure is again because of edema. Whenever there is a microbial accumulation on tooth surface, different cells come out from your blood vessels. So along with that, the some part of your vascular fluid also comes and accumulate in between the cells within the tissue. So that leads to a edema in a connective tissue that leads to bleeding. I mean, whenever you pick with the finger or your instrument, it will put on. The bleeding and throbbing is basically because of ulceration and a circular epithelium, your blood vessels are near to the surface of the liver. So when you probe, ultimately that induces it hurts the connective tissue and blood vessels that leads to a probing of the bleeding. So what is the relation of attachment loss and bone loss to a depth of pocket? Basically, you need to know what is pocket depth, what is clinical attachment loss. So pocket depth is when you consider a margin of your gingiva, the basically pocket depth is the distance from marginal gingiva to base of your pocket. Okay. From marginal gingiva to base of your pocket is called as pocket depth. So what is clinical attachment loss? Clinical attachment loss is we consider some fixed point on a teeth surface like cement enamel junction. So it is the cal is from cement enamel junction to the base of sulcus. The pocket formation causes loss of attachment of gingiva beneath the root surface. The degree of attachment loss depends on the location of base of the pocket. So when your pocket is supragingival, you will see the horizontal bone loss. When it is an intrabony, you will see the vertical bone loss. So area between the base of the pocket and alveolar bone. Distance between the apical extent of calicus and alveolar crest in human periodontal pocket is most constant. So that is having a length of 1.97 millimeter. So this is distance from calicus to alveolar bone is always a 1.97 millimeter. The distance from attached plaque to the bone is never less than the 0.5 mm and never more than 2.7 millimeter. So attached plot, the distance from attached plot to bone, bone to attached plot is never less than 0.5 millimeter to 2.7 millimeters. So these are the few aspects of your periodontal pocket. If you have any doubts, you can ask me. Hello, am I audible? Briefly, I'll summarize what we discussed today. So basically, now we know the definition. So how do you define periodontal pocket? Periodontal pocket is a deepened gingival sulcus, deepening of gingival sulcus, which is bounded by teeth surface on one side and pocket epithelium on the other side. So how do you classify periodontal pockets? Depending on the tissue involved and depending on number of surfaces involved. Depending on tissue involved, the pockets are classified as a a gingival pocket and periodontal pocket. Periodontal pocket again are divided into supra, bony, and infrabony. What is gingival pockets? Gingival pockets are because of increased size of gingiva, the pocket depth will be more without apical migration of your junction epithelium. Such type of pocket we usually see in a gingival overgrowth pieces. So these are gingival pockets are also called as a pseudo pockets. Then coming to periodontal pockets, true pockets again they are classified as a Suprabony and Intrabony. Suprabony, the name only suggests Suprabony means the base of the pocket is above the bone. Infrabony, the base of the pocket is below the bone. This is, I mean, with this is based on the pocket placement in relation to bone. So again, we classify the periodontal pockets depending on the number of surfaces involved: simple, compound, and complex. Simple means only one surface of it is involved. Compound means two surfaces and more than two surfaces. Complex means the pocket starts on one surface, twist around the two, and involves the opposite side of the tooth. So basically, these complex pockets are also called as a spiral pockets. We most commonly see these spiral pockets in a facial area. These are the These are the classification of the periodontal pocket. Coming to clinical features, I mean, whenever a patient have a periodontal pocket, they will come to with the patient will be like they'll have a dull aching pain which is radiating to the lower mandible of your jaw. I mean, lower border of your mandible, or sometimes maxillary teeth are involved. It may extend to DMJ and maxillary curiosity. Other than that, patient will always have a feeling of digging that area with some sharp instrument. Yeah, they feel like such something. There will be a dull aching pain, foul taste, foul smell. These are the few things which patient comes to your clinic with. So when you clinically examine, there will be a color change of gingiva that is bluish red, and there will be a reddish blue line which runs from marginal gingiva to base of your pocket. There will be a change in consistency, contour, surface structure, and there might be a exudation formation in a pocket. These are the few clinical features. Coming to pathogenesis, how pockets are formed. So pockets are formed because of three things. So one thing is whenever there is a plaque accumulation on the tooth surface, the number of neutrophils coming out from connective tissue to the base of sulcus will be more. So when the population of neutrophils are more than 60%, the junctional epithelium starts losing its cohesiveness. So when it starts losing its cohesiveness, obviously it is moving apically. There will be an increase of pocket pathological weakening. This is one school of thought. Again, because of host microbial interaction, there is an increased production of your MMPs, that is collagenase enzymes. These collagenase enzymes destroy the connective tissue fibers below your junctional epithelium. So once these connective tissue fibers are destroyed, your junctional epithelium starts moving apically. So again, this is treatment of gingival sulcus. That is what we call it as a periodontal pocket. And another school of thought is fibroblast as a both phagocytic and formation action of your collagen fibers. The fibroblasts which are present here in the inflammatory site, they start phagocyte the collagen fibers below the junctional epithelium, and again junctional epithelium starts proliferating on the surface apically. So there will be again increase of your periodontal sulcus growth, your deepening of periodontal sulcus. That is what we call it as periodontal pocket. These are the few theories which influence the pathogenesis of pocket formation. Again, coming to areas which we see on a gingival wall, area of presence, area of microorganism accumulation, area of leukocyte emergence, area of bacteria and leukocyte interaction, area of epithelial discarnation, area of ulceration, and area of fibrosis. These are the few zones which you usually find on a gingival wall of your pocket epithelium. I will say clinically, histologically, the pocket epithelium, the circular epithelium will start proliferating towards the connective tissue. Long elongated reticles and infiltration of inflammatory cells around these reticles and discarnation and ulceration of circular epithelium. Uh, Again, coming to the root surface changes, you'll see the area of hypermineralization, area of demineralization. There will be some degeneration of collagen fibers that leads to a granule formation on the root surfaces. A few microbes which have a capacity to enter into connective tissue. Examples are P. gingivalis, that is Porphyromonas gingivalis, Provitella intermedia, aggregatory bacteria. These are the microorganisms which have a capacity to get enter into the connective tissue of your gingiva. Any doubts? So this is about your periodontal pocket. So thank you.